Dr. Ara Deuk-Majan, CEO and founder of the Deuk Spine Institute. We're getting ready to start spine surgery. We're going to be performing a repair of 3 herniated discs in a patient's neck. She has neck pain from them. She has right arm pain, weakness in both arms, worse in the right, and she's getting pain going up to the back of her head, so we call those cervicogenic headaches. Herniated discs also can cause myelopathy, which is spinal cord dysfunction, by pressing on the spinal cord. If you look at the bottom corner of your screen, you'll see a MRI scan. It's a T2 sagittal. It has 3 herniated discs, C4-5, C5-6, C6-7. The C6-7 and C4-5 are the worst. They're pushing on the spinal cord. That's just one view, one picture, but we need to look at all the pictures, and if you do, you could see that it's pushing on the spinal cord and nerves at C4-5, C6-7, and then at C5-6 it's hitting on the nerve roots. So we're going to go back and we're going to repair these 3 discs instead of fusing them. The alternative would be an anterior cervical discectomy and fusion. That would be a long incision from here to here. It'd be very ugly. It would cause a lot of scar tissue, trouble swallowing. It could have complications from the hardware, like the metal plate, that could break through the bone, pull the screws out. Screws could migrate. They could also go into the disc above and below and cause adjacent segment disease. They could cause fusion in a bad alignment, so she could be straight with her spine instead of curved. A lot of surgeons do that by undersizing the graft. Also, there could still be residual stenosis. So fusions are bad surgeries. We want to get away from them. And this surgery you're about to watch, the Deuk laser disc repair, is the newest surgery that will be replacing fusions in the future. All right, we're going to get started. She has a nice thin neck. Now she comes to us from Florida. Shot. All right, 2, 3, 4, 5, 6, 7. 2, 3, 4, 5, 6, 7. So we're at C6. I'm going to go a little bit higher. Shot. Okay. Try to go a little bit higher. Step 1 is placement of the needle into the spine, specifically into the disc that we're operating on. 2, 3, 4, 5, 6, 7. Let's get a quick AP. Just real quick. That's it. Lateral. So I'm going to use the X-ray right now to navigate and localize. Perfect. Shot. Shot. Give me an AP. AP means front back. That looks good. Lateral. Very happy with that. We're right in the midline. We want to be in the middle of the disc when we enter it from the front. The name of this procedure is called the Deuk laser disc repair. Shot. The Deuk laser disc repair is a FDA approved procedure. It's peer reviewed and published multiple times. Shot. I've given talks on it all over the world and at the top spine meetings in the world, including the American Association of Neurological Surgeons, Society for the Advancement of Spine Surgery. That looks good. 2, 3, 4, 5, 6. So we're going to fix the 5, 6 first, and then I'm going to move up and down sequentially in that order, and we're going to repair the other discs. First, we're going to start with a discogram. A discogram allows me to see the internal architecture of the disc, find the tears, and identify the herniation. Perfect. You can actually see the herniation and the tear. Why don't you show them, Jordan, on the X-ray? You're a little bit overexposed, but Jordan's arrow is pointing at the tear in the back of the disc, the posterior annular tear. And that's what causes neck pain. And it also allows the herniation to push through the tear. That's the nuclear material in the center, and it causes compression of the spinal cord and nerve roots, which is what she has. All right, let's get a lateral view again, and thank you for reducing. You're definitely pulsing, right, on the fluoro? All right, so you guys get to watch and listen to the conversation and what we talk about during the surgery. I'm giving a little local in the skin. Typically, we lose a few drops of blood in this surgery, nothing more. So it's a pretty much bloodless surgery, and it's outpatient. The patient will go home literally an hour after her surgery. So think about a fusion. People are in the hospital for days, if not weeks, with complications. This is the entire incision right here, 4 millimeters. Can you guys see this, Henry?
We can see it, yep.
Yeah, 4 millimeters. We're going to do the whole surgery, 3 discs, with that incision. So I'm going to take this guide wire out. I'm sorry, the needle out and leave the guide wire. We're going to bring a dilator down the guide wire. Now this procedure has already been peer-reviewed and published multiple times, as I said, including this technique. It was published first 10 years ago in Surgical Neurology International, which is an online, free, open access medical journal. And for the last 100 years, if surgeons or doctors wanted to publish their findings and results of treatment, they would publish in a medical journal that would essentially require people to pay a fee in order to read that article. So in the last 10 years, there's been, or 15 years I should say, there's been more popular to publish in journals, AP, that are free and open access, meaning anyone can read the article without having to pay money. Normally you'd pay around $150, somewhere between $75 and $150 to read a medical article and lateral. But with the open access journals, the public doesn't have to pay, doctors don't have to pay. So the idea is to be able to disseminate information freely and easily. All right, 2, I'm counting where we are, 2, 3, 4, 5, 6. Everyone agree? Yeah. So on the lateral and AP, and by the way, Henry, every time I say shot, I want to make sure you're switching over to the X-ray, okay?
Yes, sir.
Shot?
Of course.
So you should be switching to the X-ray feed every time I say shot.
Copy that.
Shot? All right. Shot? So I know this looks pretty brutal, hammering this metal nail basically into the disc. Is that it? Yes, sir. But I assure you this is the safest way to do this. If you try pushing with your fingers, you'll just pass right past the back of the herniation and into the spinal cord. You can paralyze the patient. So using a mallet is the safest, easiest way to do it, and that's what I've been doing now for the last 16 years. I've been performing the Deuk laser disc repair here in Florida for 16 years. We've done over 1,500 surgeries. We've had 0 surgical complications. So unlike ACDF or fusion or artificial discs would have complications all the time, this surgery is very safe. Shot. And we've had no complications to date. Shot. All right, why don't we show, I'm going to need some inline traction because she's flexing. Let's show our audience while we're doing this and we're advancing the tube. Let's show them what causes neck pain and why do people get neck pain from a herniated disc? Why do they get arm pain from a herniated disc? Why do they get headaches? It's all due to inflammation going on in the back of the disc, right where the tear is that Jordan showed you earlier. Go ahead and play your video.
The disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
So that's the pump pressure right there. All right. Now, is there any control on the pump pressure to make it more or less? Yes. What setting are we at right now? 125. And what's high? High is like, what's the highest? I need the scope on, guys. Luis, will you help her with the scope, please? Thanks. All right. Welcome back. We are now inside the tube that we're doing the surgery. We call it a tubular retractor. It's a little fuzzy, a little hazy. All right. You can see the laser fiber. May have to, I think we have to clean this lens. Yeah, give me a second. Hold on. Go ahead. Let's take a look at that. Just looks a little hazy. What do you think? Huh? Let's get another scope ready.
Yeah, ready. On the top, Oscar.
Don't open it yet, but just have it available.
The top one, right? Yeah, that's perfect. Thank you. Just leave it as standby. Thank you.
What do you think? Hey, I need the laser on, please. When you see me go back in with this, you have to turn the laser on, okay? Don't make me. Yeah, understood. All right, so folks, we are inside the disc, the 5-6 disc. We have not taken out any of the front part of the disc or middle, and I'm in the back of the disc right where there's a tear. You can actually see there's a piece of herniation there coming up and out. Now the area that I'm working on is the back of the disc. That's where the problem is. Yeah, we're going to need a new scope then.
Opening, please. Yep.
Go ahead, Luis. Take care of it.
Stand by the light, please. Stand by the light.
We're going to switch our scope out, see if that improves the view. Sometimes these scopes need to be repaired because their fiber optic cables end up getting unglued. See, there's glue that holds them together. And we're going to just switch scopes and see. Keep this one sterile.
Yes, sir.
We're going to switch scopes and see if that helps. So, now the reason we do live streams, folks, is so that you can watch what we're doing. We're not trying to hide anything from the public. We want people to see what's done in the operating room. That's the best way to learn. Surgeons learn by going in the operating room and doing surgery. So this is exactly what we do as surgeons to learn how to do surgery. So you're getting the benefit of watching a live surgery just like a surgeon would in their training. So you're getting the exact same kind of training a surgeon gets in the beginning of their training. Now, once we watch enough surgeries, then we start doing them, little parts of them at first. Obviously, you're not going to get to do little parts of the surgery, but you're going to get to watch the surgery like a beginning surgeon does in their training. All right, let's see if this is any better. Are you going to figure out what's going on with these guys? All right, so let's see if I can sharpen this up a little bit.
Thank you. Thank you.
Now, you said this is at 125? Yes, sir. And what's the most? So, is there a more flow pump? That's your highest flow pump? Uh-huh. What do you mean for this type of procedure? Arthroscopy, you're saying? But you're talking about knees and shoulders? Because you don't do spinal arthroscopy, I'm sure. Yeah, I bet. That's because I'm the only one who does it in the cervical spine. Lumbar, there's a few other doctors. This is the herniation, by the way, right here. It's a little bit calcified. You can see the gold color. And what we're looking at, folks, this is quite interesting. There's a piece of herniation right there coming out. I'm going to tell you what we're looking at, okay? But I want to orient you. You all see the laser fibers is at 12 o'clock, okay? So that white thing on the left at 9 o'clock is the end plate of the vertebral body. And on the 3 o'clock will be the other end plate over there. You can kind of see the edge of it. And so what we're seeing here is all herniation, the blue stuff. All this stuff that I'm zapping away is a herniation. It's at the back of this disc. The herniation is not in the middle of the disc, it's not in the front of the disc, it's not on the sides. It's literally a small area in the back of the disc. And you guys saw the video we just played that shows you the herniation and how it forms. It starts with a tear within the annulus in the back, right where the spinal cord and nerves are. And then through that tear, the jelly, which is located in the middle of the disc, pushes out. These are all pieces of herniation right here coming out. Okay, so we're freeing them up and taking them out. And we're doing all of this. These are all pieces of herniation. We're doing all of this without opening the patient up with a big incision. It's all being done through a 4mm incision. So what that allows is it allows the patient to have a quick recovery and not have trouble swallowing, not have scar tissue, like open surgery creates scar tissue. If you're having an ACDF fusion, you're going to get scar tissue, big time. If you're having an artificial disc, you're going to have big time scar tissue. That scar tissue is going to be there the rest of your life. It's going to affect the way you swallow, the way you talk, your hoarseness. You'll have some change in your voice that will be permanent from the surgery. With the Deuk laser disc repair, you don't get hoarseness, you don't have trouble swallowing. You get a little irritation of your trachea from the tube being down for the anesthesia because you're asleep for the whole surgery. The same as you would for an ACDF, but you don't have the retraction of the esophagus like we do with an ACDF. You don't have the recurrent laryngeal nerve injuries, which cause hoarseness, or the soft tissue damage, which causes hoarseness. So none of the soft tissue damage of a fusion or artificial disc occurs with this surgery. These are all pieces of herniation. And you can see there's lots of them. A lot of people think herniated disc is one piece. It's actually usually around 20 to 30 pieces by the time people get surgery. There's a piece right there. That's a big one. All right, let's take a question, and then we're going to play a video that shows you how the Deuk laser disc repair works.
All right, this question comes from Davey Slater on Facebook.
Hi, Amy.
Davey Slater.
Davey Slater.
Yeah. And they asked, why do you do spine from the front?
Why do we do spine surgery from the front? The answer is the problem is in the front of the spinal cord. That's why. So you can either do spine surgery on the neck through the front or the back. The surgeons that go through the back are not doing it properly, because going through the back is, if you don't really know how to do it through the front, you go through the back. Now, there is an exception to that, and that is if you have to do more than 3 discs. If you have to do 4 discs, then going through the back and doing a laminectomy is normally the right way to do it. But this surgery can only be done through the front. When you go through the back, you have to remove the lamina, the facet joint, ligaments, soft tissues that hold the spine together. Oh, look at that herniation that just came out. Look at that. Right out of the foramen on her left. So she does have left arm weakness as well. And that comes from pinched nerves. And that piece of herniation was pinching on her nerve. Yeah, so going through the front of the neck is the right way to do it. It's like anything in life. There's more than one way to skin a cat, they say. There's more than one way to do things. There's the best way, and then there's lots of other ways that aren't the best. And surgeons that can't do the best way because they don't know how, they do the second best or third best or fourth best because that's how they've been trained. And they haven't had the benefit of the right training, in my opinion. But when you've been trained to do everything the best, and you know how to do it the best, then you choose the best. The best is through the front, not through the back when it comes to the cervical spine. All right, what we're looking at are the end plates there, and this is the back of the disc, right where the herniation is. You can see a lot of scar tissue, a little bit of bone spur there, but this is going out into her left foramen, and this is all herniation here that I'm taking out. And we're going to do this at each level. Now, it may look big to you, but that opening is just 4 millimeters. There's herniation right there in the middle. It's calcified. Ooh, look at that. See that? Billowing out. It's one of the nice things about the laser is that it creates a sonic wave, like a pulse. And that sonic wave helps remove the herniation. So the laser is far better than any other tool available when it comes to doing disc surgery. For several reasons. It's extremely precise. That fiber there you're looking at is 0.5 millimeter, 0.5 millimeters. So think about that. There's no other surgical tool, there's a herniation, that's 0.5 millimeters. I'm going to break this one up with a laser just to get it into smaller pieces so it comes out easier. So the laser is the most precise surgical tool we have. And that's, you're operating near the spinal cord and near the nerves, so you want to be as precise as possible. And that's what we're doing. You saw how skinny the tube is. Just think about that. That metal tube right there, it looks big in this view because everything is magnified. Oh, there's a herniation that just came out from the epidural space. You see that? That was pushing on the spinal cord. I'm going to go in and grab it out. So take a look. We'll do it later. I'll show you the difference between the skinniest surgical metal tool, which is the pituitary rongeur I use, versus the laser fiber. And you'll see how much smaller the laser fiber is. It's far more precise. All right, great question. Any other questions from our audience?
Yes, we have a question from Dynamic Disc Designs Corporation from Facebook.
Hi, Jerome. How are you? Good morning from British Columbia.
And he asked, why is it the back of the disc that is most often the site of the problem?
Why is so the question from Jerome Fryer, who makes, by the way, is a friend of mine. I've known him for years, and he does a lot of things, but he is a chiropractor and therapist for people with back and neck pain. But his passion, I think, is creating spinal models of the spine to show pathology, like what's going on, because a lot of people have a hard time visualizing what a herniated disc looks like, what spinal stenosis looks like, what facet arthropathy looks like, what a pinched nerve looks like. So he has literally the best models in the world. And Jerome, I need to talk to you because I need some models made. And I want to discuss them with you. One of them needs to be, I need to have several segments in a row, maybe three discs, with the top one being normal, And then the next one down having hypertrophied facet, kind of like moderate, and then the bottom one being severe facet hypertrophy, and showing how facet hypertrophy, where the facets go from being normal size, 1x, all the way up to like 3 or 4 or 5x, 5 times normal size. And I want to show that progression of over time of what happens and how the facets get so big and how they can pinch the nerve and narrow the foramen and cause stenosis and radiculopathy. So that's one model. Another model is I want to show how the ligament that buckles, the ligamentum flavum from the back, will buckle in and hit the nerve as it's exiting. And then I want to show how a herniated disc bulges back and hits on the nerve in the foramen as well, causing nerve compression. So I want to talk to you about building those models, and I want to get multiples of each one. So let's talk about that later. But to answer your question, the reason why, the question was, why do herniations happen in the back of the disc? And there's really two parts to answer this. Number one, that's a spinal cord, by the way, right there. You all see that? That's a spinal cord. And that's where the herniation went out, right through that hole. That's the annulus, posterior annulus, and the posterior longitudinal ligament back there, okay? And you can see the herniation tore a hole in the PLL and was pushing on the spinal cord right there, okay? But it's gone now. I've decompressed the spinal cord centrally. Now I'm going out the foramen. So Jerome asks a great question. He says, why are the herniations always in the back? And the answer is they're not. They're not always in the back. But the ones that cause symptoms are always in the back. You see, herniated discs in the front of your disc don't cause symptoms. Herniated discs in the sides of your disc don't cause symptoms. Only herniated discs in the back cause symptoms. So that's point number one. So we don't treat patients without symptoms. So basically, as a surgeon, you want to find patients that have a posterior disc herniation that has symptoms from it that you can fix by operating, okay? So a front herniation doesn't do anything, doesn't cause any symptoms, doesn't need to be treated. A side herniation of the disc doesn't cause problems or symptoms, doesn't need to be treated, but the back herniations do. And now, why do herniations happen in the back? Well, because number one, the biomechanics of the spine. The way the spine is curved in the lumbar and the cervical spine. It's in what's called lordosis. So the instantaneous axis of rotation through the disc space is really favors, it's in the back, and it really favors damaging or compressing the tissues in the back of the disc. So it causes damage. There's a herniation coming out of the foramen on her left again. Our job is to remove as many of those as we can. So the disc herniations that cause symptoms are always in the back of the disc. That's where the fibers are for pain that you can feel. So people feel those herniations. They cause horrible neck pain. And that's where the nerves and spinal cord are. So if those herniations push on the nerves, it'll cause weakness in the arm, numbness in the arm, tingling, or pain down the arm. So our goal here is to get rid of her neck pain and her headaches by debriding the annular tear, get rid of her arm pain by debriding the annular tear, because that gets rid of the inflammation that causes the neck pain, the headaches, and the arm pain. And then we want to get the pressure off the spinal cord and the nerves. It's called the decompression. And that gets rid of the weakness and numbness. But it takes time for those nerves to heal. You have to be patient. Sometimes it could take a year for the weakness and numbness to go away. But the inflammation goes away right away. All right, you can see there's some herniation on her right side at C5-C6 as well. But we got a lot of herniations out on the left, from the left foramen. Now we're over on the right foramen. And it's going very well for her. There's another herniation. You see that thing? It just came out of the foramen, the neuroforamen. It was sitting on the nerve root. There's more pieces. They're all little pieces. So has anyone kept count? How many herniations have we gotten out of this one disc? We've gotten probably at least 20 so far, and we're not done. There's the foramen right there. You can look into it. Okay? And there's a lot of little pieces of herniation still coming out. You can actually almost see the nerve root right there. All right, so we're almost done with C5-6, and we're going to go do probably C6-7, and then we'll do C4-5 last. But you can see the back of this disc. This white stuff's all scar tissue. That's from the inflammation that was happening at the back of the disc where the annular tear was, where the herniation, the nuclear material, was irritating the inflammatory system, causing chronic inflammation and pain. Okay, here's bone spur right here, taking them out. All right, you can see the end plate. You can see the end plate. That's the end plate of 5. That's the end plate of vertebral body 6. So that would be the inferior end plate of 5, the superior end plate of 6, and this is the back of the disc. Thanks. And you can see the foramen is now open. I'm going to pull the tube back a little bit just to get a better view of what's going on by the foramen. All right. I want to do a shout out to Joe and Flynn because we miss you guys. And wish you guys were still here, but wish you all the best. Right, Luis? All right, let's check the other side. All right. Any other questions?
No current questions.
All right, let's run the video showing how does the Deuk laser disc repair actually do its job. What are we doing back there? So kind of give people a view of what we're doing, animation style. All right?
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Done with C5-6. We've just put the antiseptic in. We've never had an infection with the Deuk laser disc repair. 16 years, 1,500 patients. Not a single infection. And we always give antibiotics, IV, but also we do an antiseptic, which is like an antibiotic, but not really. It's not the kind you put in the vein. Yep. Come on in. And it's topical, meaning we put it down the tube, and it's pretty standard for endoscopic surgery to use antibiotics, with any surgery as a matter of fact, to minimize the risk of getting an infection. I've seen infections from epidural steroid injections. I've seen infections from spinal fusion. We've seen injections from laminectomies and discectomies and foramenotomies, but we've never seen on infection from a Deuk laser disc repair, and we're going to keep it that way. All right, coming out. Can you see okay?
Yep.
All right. Shot. Shot. All right, you can see then that the dilator tip is still in the back of the disc, but the tube is out. Now let's show them the tube. Can you guys see this, Henry? Go ahead,
Yes,
release it.
we can see it.
This little metal tube, just get an idea of how small that is. The whole surgery is done with this tube. That's what endoscopic, true anterior cervical, going through the front, transdiscal endoscopic surgery is all about. Tiny tube, tiny incision, no fusion, no metal, all natural. We're just repairing the back of the disc. It's called the Deuk laser disc repair. It's been peer reviewed and published, like I said, many times. It's all FDA approved. All right, Luis, where are we going next? Down. Luis wants to go down. All right, so if you look at the top, show everybody C2. Can you see the x-ray?
Yep.
Henry?
We can see
You
it.
see the white arrow at the top there?
Yes, yes.
All
Now we
right.
can.
That is the number 2 bone, and then you got a disc. Show them the disc. Then you got another bone. That's square. Then you got another bone. So that's 2, 3, 4, 5, 6, 7. So we're going to go down and do the next disc as C6-7. All right. You can see there's minimal bleeding throughout the procedure. Just a little bit of vein bleeding. I'm going to hold pressure for just a minute. We usually lose about 2 milliliters on average, which is 20 to 40 drops. 1 milliliter is 20 drops, 2 mils is 40 drops. So very minimal blood loss. Blood pressure is good. Vitals are good. Patient's asleep. All right. Just hold pressure for 1 more minute. Huh? Chemically blocked, so they can't move their muscles. Now, the reason anesthesiologists use what's called neuromuscular blockade or chemical paralysis during general anesthesia is so they can ventilate the patient's lungs. Otherwise, if the patient's muscles are contracting, they won't be able to push air into the lungs, and they could blow the lungs out by increasing the pressure. So to allow the thorax to expand and contract against the muscles, you have to relax all the muscles. And that's why they give muscle relaxer. Now, the second reason we do muscle relaxer is to relax the neck muscles so I can actually feel the spine and do this surgery. All right, so you can see the incision is tiny. It's 4 millimeters. We're going to now move down to the next disc. Shot. 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 I want to stay in the middle. Shot. All right. Here we go. Shot. There we go. Shot. All right, that's it. Nice. Let's do an AP and just see where we are. We want to stay in the middle of the front of the disc. There's a ligament there called the anterior longitudinal ligament. Lateral, that's perfect. And the anterior longitudinal ligament, it literally runs from the top of your spine all the way down to your sacrum or tailbone. And it acts as a support ligament for movement so that you don't move too much. Keeps your bones lined up. All right. So we're going to stay right on that ligament. Shot. That's it? Shot. 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 AP. So I've moved down, staying and gliding right along that ligament. And that's very important. Hold on, shot. Good. Yep. And let's see, go lateral. So we're at the next disc space. Wait, I want to see where we are in the lateral view. Good. I want to go to the midline a little bit. There we go. Shot. And there's little veins sitting right on the front of the spine. I need another AP just to make sure we're in the midline. You're holding. Shot. Shot. Perfect. Lateral. This, by the way, is the hardest part of the surgery, in my opinion, is moving from one disc to the next. But you can see we're right in the center. So I'm going to anchor the tip into the front of the disc. Once I get it anchored, shot, I'm going to change my trajectory and make it parallel to the end plates. Okay? Shot. Now when I get center, I'm going to clean out whatever disc material might be sitting inside this hollow part of this thing. Shot. Shot. Good. And then I'm going to do a discogram. So we have the benefit of the two types of dye we use in our discogram. Now we've shown the audience why people get neck pain and arm pain, right?
Yes.
And we've shown the audience what the Deuk laser disc repair actually does.
Correct.
Shot. All right, show them. Look at that tear, guys. Show them the tear at C6-7. Huge tear in the back of the disc, and the dye's leaking out. There's the herniation right where the arrow is. Are you on the X-ray?
Yeah, we see it.
All right, perfect. See how big the herniation is there? Huge. So now I'm going to go to the back of the disc, shot, and I'm going to bring my tube in. And look at that. We're going right along that tear, right to the back, right where the herniation is. And I'm not going to damage any of this disc at all. I'm leaving the natural disc there, the good stuff. 95% of this disc is normal. We're not taking any of the normal disc out. We're only going to take that herniation out in the back. You understand? That's why this surgery is so incredible. If you do an ACDF or an artificial disc, you're taking the whole disc out just to get to the part in the back. Now this whole concept of leave the whole disc there and just get the herniation out, that was the Koreans who developed that. I actually thought of it as well, but I didn't know how to do it until I encountered the Koreans who had developed that part of the surgery. They were taking herniations out this way, transdiscal, endoscopic, before I was. Shot. But what I developed was the annular debridement, which is where we go in and clean the annular tear. And that's, in my opinion, more important than even removing a herniated disc, because the herniated disc will come back again if you don't debride the tear. Shot. So I got to advance this tube, but I got to not let the dilator go too far. It's gone a little bit. Shot. Got to keep an eye on it. Shot. Yep, perfect. It's helping. It's helping. Makes a big difference when you do inline traction. All right, so I'm almost there. I'm a few millimeters, about 5 millimeters away, and I want to re-advance this dilator. That's good. Now it's sitting in the herniation. Shot. Perfect. The dilator tends to come back as you're advancing the tube. That looks really good right there. I'm happy with that. So we're literally at the back of the normal part of the disc, right where the herniation's going out through the tear. Let's show them, the audience, the herniation again with the first video, what causes neck pain. You can see a tear forms in the back of the disc, and the jelly from the center called the herniation pushes out. That's all we're removing, folks, is the herniation, and we're cleaning up the tear so it'll heal itself. That's the beauty of the Deuk laser disc repair. You won't find it anywhere else in the world.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, we're back at it at C6-7 now. We're removing our pieces of herniation. You can see the annular tear at the bottom there. The annular tear goes from end plate to end plate. You can see that there's some kind of yellowish orange material. That's calcium deposits from dystrophic calcification of the herniation. This is all herniation here, right here that I'm zapping away right now. Sitting right in the annular tear, blocking the annular tear from healing. So you want to know why discs don't heal on their own? They don't heal because of the herniation. Sits right in that tear and prevents it from healing. There's a piece of herniation right there. So what I do with the Deuk laser disc repair, I remove the herniated fragments that are keeping the tear from healing. And then it's called a debridement. And I clean up the scar tissue, get rid of it, clean up the calcium, because all that stuff is just going to prevent the disc from healing. So we call it a debridement. Debridement is not something new in medicine. It's been around for years. We do debridements in medicine all the time when you have a non-healing lesion. Like if there's a problem with your body and it won't heal, whether it's your skin, whether it's a tear in the shoulder with one of your ligaments or tendons, the surgeons go in and we debride that, dead tissue out, that bad stuff, and that then allows things to heal properly. So really, if you want to know what we're taking out, degenerated herniated nucleus plus calcium plus scar tissue, basically an inflammatory mass. That's what we're taking out. A mass of inflammation that won't go away on its own. So we're giving this patient's body a chance to heal itself by getting rid of this bad stuff, blocking it from healing. All right, any questions from the audience?
No current questions.
Yep. Again, this surgery has been published in the medical literature multiple times, about 9 or 10 times, with good long-term outcomes showing that patients get great relief of their pain. The averages, depending on which study we look at, how much time, it's around 92% elimination of the axial pain and around 90+% elimination of the radicular symptoms as well. So it's better than fusion, better than artificial discs, better than laminectomies in terms of relief of symptoms, and the durability is very good. We looked at Deuk laser disc repair patients that had lumbar for the lower back pain, a minimum of 5 years of follow-up. We ended up with 6.5 years on average for the group of follow-up. I'm sorry, not 6.5, 6. And the results were 92% elimination of their back pain, still at 6 years. And 92% elimination of their leg pain. I think it was around 93. So pretty incredible. You don't have those results with any other type of spine surgery. So this is the future of spine surgery because the results are so good, because it's so minimally invasive. The cost is lower than fusions. The acuity is lower. It's safer. And the outcomes are better. There's no hospital stay. It's all outpatient. There's none of the complications you get with fusions either. Those complications can be really bad. All right, that's the foramen, neural foramen you hear about all the time. Right there, we're looking into it. There's some grunge right outside the foramen, but you can actually see the nerve root down there behind that blue. We're not going to mess with that. And that would actually be the, if it's coming out the foramen at 6-7, that would be the C7 nerve root. That goes to the triceps. And that's her right side. Right side. She had weakness in her triceps before surgery. I checked her out in clinic yesterday, and I also checked her out today in pre-op, and she had weakness of the triceps. Look at it, still more herniation. This stuff is right outside the tube, and it's all right there in that back of the disc. Needs to go. So we're going to do our best to take it out. Like I said, the grabbers are not great at removing things because everything is stuck down. Typically in an ACDF, we'd use a scraper to scrape this out, or a drill to drill it out. Why don't we show our audience what an ACDF looks like to fix this kind of problem? Let's do a comparison between ACDF and Deuk laser disc repair.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
Welcome back. We are at C6-7, and you can see these are fibers of the posterior longitudinal ligament at the back of the disc. A lot of scar tissue here from chronic inflammation, a bone spur there. But we've cleaned out the herniation for the most part. There's a little bit left. There's a piece right there we need to get rid of. Float it out.
We have a question from YouTube.
Sure.
This comes from Trevor, and he asks, does Dr. Deuk do any more fusions at all?
Does Dr. Deuk do any more fusions? From Trevor. Thank you, Trevor. As a matter of fact, I do rarely do fusions. Why don't I do fusions? Obviously, fusions are very invasive and destructive and long recovery, narcotic painkillers, risky, dangerous. They don't have as good a result as the laser. So there's every reason in the world not to do fusions. But some people, they need a fusion. And I'll give you an example. There was a herniation up against the spinal cord. Somebody has a C1-C2 instability. I got to do a C1-C2 fusion. We're actually going to be doing an anterior cervical discectomy and fusion in a couple of weeks right here, because that patient has such bad malalignment of her bones, and they're slipping sideways and backwards, that the laser surgery is not appropriate for that kind of person. So I would say 95% conservative of fusions can be eliminated with this procedure, but there's still going to be the occasional patient with such severe disease that the laser won't work. And that's the minority of patients, of course. Only 5% of those who need surgery won't be able to have the laser because their alignment is so bad, the discs are so collapsed, the bone spurs are so big. There's a lot of reasons, potentially. But the vast majority of the people that get fusions don't need them. I don't know if that answers your question, but yes, I still do fusion. I've done 1,000 cervical fusions in the front, and I've done 500 through the back. So I do them, I could do them in my sleep, so to speak. I can do them very, very easily. As a matter of fact, they pay a lot better than laser surgery does. But that's not the reason to do it. And unfortunately, most surgeons use that as an excuse to do fusion rather than endoscopic surgery, which doesn't pay as well. All right, just about done here at C6-7. We've already fixed C5-6 herniation, annular tear. Now we're doing C6-7. I don't see any more pieces of herniation out there. I've cleaned up the middle real good. Now I'm going to go to the other side, which is going to be her left. And I've already been here a little bit. I'm going to come back and check it out. A lot of scar tissue. That's all the white stuff. Yeah. You can actually see a few last fibers of the PLL. Watch that laser fiber on me. I want to make sure we get everything in there. You can see how the laser is wonderful at getting these pieces to move around a little bit, loosen them up. I'm going to have to cut through the PLL right here because I think there may be a herniation behind it. See that? How it's crawling over there? So I'm going to have to cut through the PLL. This is not it yet, but right here, this is cutting through the PLL. You have to be careful because the spinal cord sits right behind there. You can see how the laser gently peels away layer by layer of the PLL. Now, remember, I've done 1,000 cervical fusions. You see the herniation sitting there? That's the herniation right there. You see how it's trapped underneath here? And I'm kind of freeing it up by removing the PLL. Sometimes you have to remove part of the PLL to get all the herniation out. That's the herniation right there. But there's only a little bit left. It's sitting right on top of the dura. I'm not gonna, it's not pressing on anything, and it's scarred down, and it's not causing any symptoms at this point. So I'm gonna leave the rest of it alone. There's an old saying, don't gild the lily. And, you know, do what needs to be done and nothing more. People get the wrong idea. They think that when you do spine surgery, your discs are going to be normal looking afterwards. They never look normal. Your discs are never going to be normal again once they have been damaged, okay? Our goal is not to make your disc look normal. If that was the goal, I would never do surgery because it's impossible. No surgery makes your disc look normal. What our goal is to get rid of your pain in your neck, your headaches that are coming from your disc herniation, to get rid of your arm pain, your numbness and tingling and weakness in your arm, and your pressure on your spinal cord. That's the goal. Get rid of the spinal cord pressure, the nerve pressure, the chemical irritation of the nerve and spinal cord and dura, which causes arm pain, neck pain, headaches, And this is the last of the herniation. These are some pretty hard pieces. That's fine. So notice how I blasted them a little bit to get them to float out. It's always easier to float out the herniation than to try to grab it out. Grabbing them is a little more challenging. And if you can float them out, much better. Just about done. A little bit of herniation here left. Now, if you're interested in seeing if you're a candidate for the Deuk laser disc repair, go to our website and we have a free MRI review page where we will take your MRI, you can upload it to our website, and then we'll look at it, I will look at it, and I'll meet with you and do a free virtual consultation using Zoom. We'll send you a link, give you a scheduled date, and we can actually figure out if you're a candidate for the Deuk laser disc repair using that. So everything here is looking good. Maybe clean a little bit more of this. Again, I don't want to gild the lily. I don't want to do too much and then I regret it because I create a problem. A little bit of herniation right there. The rest of this is looking pretty darn good. I don't see any more herniation back here anywhere. There's just a little bit of it stuck down. So I think we're good. I may want to take another look right here. There could be some right here. Any more questions from our audience?
No current questions, no.
See how the laser peels away about, all right, the width of that tube is 1/2 millimeter. So imagine I'm able to peel probably 1/10 of a millimeter at a time. So very, very small amounts. This has been here for a long time. Look at that. That's all calcified and scarred up. That's a foraminal narrowing right there. Look at that. All right. That looks good. Now she'll be sore for a few days after this, but her arm symptoms should go away. It might take some time. Everyone's a little different. There's a bit of herniation right there. The only question is it clinically significant? That's really the question you have to ask as a surgeon. Is what's left clinically significant? Meaning, is it causing symptoms? That seems to be digging in. So I am going to treat that. That looks good. Just a thin strand left right on the spinal cord. So that's good. That's as good as we can do safely.
Lights on, please. Thank you.
I'm happy with that. We've fully decompressed the spinal cord and nerves. I've gotten rid of 95% of that. Oh, this is the antiseptic. Can you guys see this, by the way? We call it, it's called betadine. It's developed by NASA. And it was used by NASA as an antiseptic for space to kill anything the astronauts might encounter going up into space or bringing back to Earth on the space shuttle. During the early years of space exploration, there was always concern about bringing back alien life forms that could take over the world, right? We've all seen War of the Worlds. You've probably watched Prometheus. If you haven't, you got to watch it, or Aliens. But that's always been a fascination of us, is what's out there and is it dangerous to humans? So of course, when you send a spaceship out in outer space and it's collecting things like little things moving around space at 20,000 miles an hour, it hits the spaceship, maybe a gob of green stuff, and they bring it back, right? And then now you've infected Earth. So, huh? And ANSEF doesn't work, right? So you need betadine. All right, beautiful. So 2, 3, 4, 5, 6, 7. Now we got to march our way back up to C4-5, and that will be the third disc we're doing today. I'm going to start by taking this tube out. You can see the tube coming out gradually from the disc. And it always looks bad when you take the tube out, but you know, I assure you, the tube is very skinny and it passes through the substance of the disc. Think about the substance of the disc as like silicone. So when you take the dilator and the tube out, the silicone just collapses back on itself. There's no damage because the jelly in the center of the disc we're passing through is inert and it's not really active. It's inactive tissue with very few cells. You can see the incision. Again, a little vein bleeding, which is typical. All right, we're going to move out of this disc and work our way up to 4-5. Any questions for me?
No current questions.
All right, let's go ahead and show our audience a video of what the Deuk laser disc repair actually does, in case they missed it earlier.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
5-6 in a prior 5-6. So at this point, we're using the X-ray machine called a fluoro to navigate our way back up the spine. I've left 6-7. I'm in 5-6 once again, where we already treated. And now I'm going to move up to 4-5, C4-5. Remember, she has 3 herniated discs, all causing symptoms. We want to treat them all while we're here. I don't want her to have to come back and have more surgeries. So we do everything in one shot. We do multi-level surgeries. Been doing it that way for years. And that way people don't have to have more than one surgery. A lot of surgeons will only fix one disc at a time, and that makes the patient have to have multiple surgeries. AP. Huh?
More anesthetics.
Yeah. Tell me when you're ready. Huh?
Ready?
Shot. 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 Lateral. All right. Shot. So we're almost there, about a centimeter left. Shot. And remember, when you do this in the future, if you become a neurosurgeon and you do this surgery, you want to make sure you use both AP and lateral views, because using one view only will not work. Shot? You have to use both. No, give me a shot. Give me a AP. Huh? Give me a shot. Off to her right. I want to be a little more center. Hold on. You can actually feel the front of the disc. Shot. Perfect. Lateral. So we're right in the middle on the front view. And I want to check the side view once again. Yeah. 2, 3, 4, 5. Everyone agree that's 4, 5? Shot. All right. So I want to verify I'm in the middle again. Shot. Let's get an AP. Listen, if you do this kind of surgery, you've got to use 2 views, at least 2 views, AP and lateral. You don't need anything more than that. Shot. But if you don't use the AP and lateral, you're putting the patient at great risk. There's no way you can just use the lateral view. Okay? Not with the cervical. You have to do both. So 2, I'm counting C2. Count with me, Jordan. Are you over on the X-ray, Henry?
Yep.
2, 3, 4, 5. C4, 5, that's where we want to be. Going to advance the dilator. Let's go, Jordan. Clean out any of the nuclear material. Shot. Shot. Good. Now we can do our discogram. So far, her surgery is going well. Shot. Perfect. Look at the giant tear. And you can see the herniation. Show them the tear at the X-ray. Can you see that, Henry?
Yep. You can see it.
There's the tear, and then show them the herniation right there, bulging out, right against the spinal cord and nerves. You can see 2 herniations, one on the left, one on the right. All right, now getting back to Dr. Jerome Fryer's comment. Why are most herniations in the back of the disc? There's, as I said earlier, if you have a front or a side herniation, it doesn't cause symptoms, so patients never get treated for that. They don't even get the MRI done. So we don't know the true incidence of front or side herniations unless you just take all comers, asymptomatic people, and see, if they have side or front herniations. But the innervation to the front and side of the disc is what are called visceral afferents, which don't go to the part of your brain that maps very, very specific pain signals. So you get what's called non-specific pain when it's injury to the side or back of the disc with inflammation in the side or back. Shot. On the other hand, posterior part of the disc is innervated by branches of the sinovertebral nerve, which carry somatic afferent fibers, which transmit pain signals to your somatosensory cortex, which allows you, is that it? Shot? Which allows you, the patient, to feel pain. We have a part of our brain that's relatively new, meaning it's just a few million years old, as opposed to the older parts of our brain, which are like the brain stem. We have really 3 parts of the brain. The paleocortex, which is the oldest. The archicortex, which is, I think, a few million years. And then the neocortex, which is the newest part of the brain. And the part of your brain that senses very strong localized pain is your neocortex, the newest part of the brain. It's only a few million years old. Fascinating, isn't it? Anyway, that neocortex is the part of the brain that tells the patient exactly where their pain's coming from. A long time ago, when we were just swimming around in that primordial soup of the ocean, we were like slugs, and you know, you just needed like movements away from painful stimuli, noxious stimuli. But now that we're sophisticated multicellular organisms, you need a better sensory system that can give you more localized pain, so you can sense whether you've got little things going on that need your attention. And that part of your brain is called the primary somatosensory cortex. It's located in the parietal lobe. And if you watch the video again, let's run the video one more time and show our audience how they feel pain signals. Pay attention to the end of the video where you watch the pain signals go from the back of the disc up to the primary somatosensory cortex, where your brain then maps out exactly on your body where your pain is coming from, using a map system that's literally millions of years old now.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. And we're just finishing our Deuk laser disc repair here at C4-5. We've already treated 5-6 and 6-7 disc herniations. You can see all the little fragments of herniation coming out with the laser surgery. We're releasing these guys. That piece that just went up looked like a crab, and those little furry things that you saw, if you go back and rewind it, basically that's a new herniation fragment. The older herniation fragments get scarred up and they look smoother. They don't have all those fine little fingers like that one you just saw. Like, this is old part of herniation, and this is a newer part right here, this blue stuff I just blasted. This is the annular debridement, by the way. This is unique to the Deuk laser disc repair. Can only be done with the Deuk laser disc repair because we're the first to publish it, the first to describe it, the first to do it. But when you're having a fusion, they don't bother repairing your disc. They just take your whole disc out and they fuse it, so you don't use the disc anymore. You lose all that movement. And why would you ever want to lose movement in your neck? I mean, God put movement in your neck for a reason, so you can look around. Why would you ever want to fuse your joints so they don't move anymore? The answer is that's all we knew how to do for many years. And so that's all surgeons are trained to do. And the problem is, to do fusion, you need metal. And metal makes millions. Just remember that. Metal makes millions. It should actually be billions, because the companies that sell the metal, they don't want laser surgery out there, because this surgery represents the end of their business. And by the way, when those companies no longer are needed and they're no longer putting metal in your body, your surgery is going to cost a lot less. These surgeries are half the price of fusion surgeries. Okay? They're cheap. compared to fusion. All right, we'll take our question.
Yes, we have multiple questions. The first one comes from, forgive me if I say this wrong, Rigaleb on YouTube. And they asked, have you seen blood clots post-op? Otherwise, do you prescribe anti-coags after the surgery, especially if the person has a genetic predisposition, like in knee surgery?
Hi, thank you for asking. That's a great question. So do we see blood clots as a complication after the surgery? The answer is no. We've never had a blood clot, no deep venous thrombosis, no pulmonary embolism ever. And the reason is that the surgery is so quick and light. There's not like laying around in bed for weeks afterwards that people do with fusions. People are up, back to work the next day. So you're back on your feet, you're mobilizing, you don't get blood clots when you're up moving around, okay? So that's why this surgery doesn't get blood clots. Now, do we do precautions? Absolutely. We give sequential compression devices, which are leg squeezers, to keep the blood moving during the surgery, and for a few days after, we give TED hoses, so patients have preventive measures in place. We also give them a shot of heparin sub-Q in the recovery area, I believe, right? Where's my nurses? We don't do the heparin sub-Q? Okay, well, we used to. But the point is, you really don't even need it, to be honest, because the risk of blood clots with this surgery is so small, because this is not, like hip surgery where people are down for weeks laying in bed and can't get out of bed because they're in so much pain. These patients who get this surgery are back on their feet right away, so the risk of getting blood clots is very low. Now,
The dimensions of the incision very small.
and the incision is very small,
So the
yeah.
ball cut surface area is minimal.
Yeah, so the surface area is very small. So the risk of getting blood clots is very low. Now, somebody has a genetic predisposition like protein C, protein S deficiency, then they would need to be cleared by their hematologist for the surgery. But yeah, I think we could probably do it. I'd have to talk to my anesthesiologist. There's a spinal cord down there, by the way. See the vein on top of the spinal cord? Pretty cool, huh? So you can see how big the tear is. It's literally ceiling to floor tear. And we saw that on the discogram, by the way. If you remember, if you go back, it was a big tear. So that discogram is very important. There's a piece of herniation. I'd say we average about 30 pieces of herniation per disc when we do these surgeries. We see about 30. 30 pieces. Wouldn't you say, Luis? Probably 25 to 30, somewhere.
We have a couple more questions.
I'll take your questions, absolutely. Feel free to type your questions up. That's why we do question and answer during surgery, so that maybe if you have a question about what I'm doing right now, like zapping that piece of herniation away, I can answer it. But go ahead, what's the next question?
This next question comes from Blue to the Sky on YouTube. And they asked, how can you find the target disc is decompressed enough? I mean, when you stop shooting the laser to the disc until you see the dura of the spinal cord.
Well, it's not necessary to always see the dura, okay? You only want to see the dura when the injury goes all the way through to the dura. A lot of herniations are what are called subligamentous, meaning that they don't penetrate the posterior longitudinal ligament all the way. So if they don't penetrate the PLL all the way, you won't see the dura. The only time you're going to see the dura is when they do penetrate. Like this little bit of herniation right here, I'm literally just zapping it right off the dura, right off the spinal cord. You can actually see the dura down there just through that crack, all right? But you can see most of the herniation here is above the dura. It's within the disc of the dura. It's on the disc side of the dura. So, it just takes, honestly, a good sense of anatomy by the surgeon, knowing where the different layers are, the different structures are, and just being really careful and having the right tools, the right training. This surgery is not hard to do, to be honest. If you're trained properly and you have the right equipment and the right staff helping you. This would be impossible for me to do if I didn't have the team I have. Like my nurses, my assistants, Luis, my anesthesiologist. My God, if I didn't have the right people helping me, it would be a nightmare doing this surgery. It would be very dangerous for the patient. So having all the right people, having all the right equipment, having the right training, having the right medications, all of that is so important. And we don't talk about all those details very much during these surgeries because I don't want to bore you all to death, but the reality is it's taken me many years to get everything just perfect. And you can see these surgeries go flawlessly. In the beginning, it took a lot more effort because I was still learning because I was developing the technique. But now we've got it down. And it's kind of like once you've created the perfect, there it is, a piece of herniation right there in the foramen. Once you've created the perfect surgery, it's hard to improve upon it much more. So the amount of improvement I've done over the years has been very little. And it's pretty standard, you know. So as far as when are you done, you're pretty much done the same for every surgery. You're just looking for the PLL. You want to know if there's herniation through the PLL. If there is, you got to chase it and you got to get it out. So I inspect the PLL. You got to know where the back of the disc is. You got to know where the spinal cord is. And you got to avoid injuring it. And yes, I do make it look easy. You're right. But it's not this easy. It takes a lot of skill and practice to get it just right. There's so many ways you can mess this up. And it would be really bad for the patient if you did. But that's why you got to get neurosurgery training. You know, you have to become a very skilled spine surgeon to be able to do these surgeries. But we just broadcast it for you so you all can see what we do. And you can become aware of what's available, the newer technology. Everyone that has neck pain thinks it's uncurable, or they think that they have to have a fusion or artificial disc, but you don't. There's far better technology now available. Safer. All right, just about done here. Getting rid of the last pieces of herniation. This is some scar tissue. It's not doing anything. It's not hurting this patient. And I'm just going to take what I can get, and that's it. I'm not going to go crazy here. You don't want to cause a complication. Surgeons that go overboard, they cause complications. And I'm not going to do that. I value my patient's health too much. This is not me. It's not about me. It's about them. And I got to do what's best for them. You know, that's my obligation as a doctor. All right, we're pretty much done here. I don't see anything. I'll look one more time. But I think we've done a good job. Maybe there's a little bit right here, Luis, just a little trim there. I'm going to try to trim that up a little bit. That's kind of the edge of the tear. Uh, 2 minutes. Looking pretty good. Little bone spur right there. Looks good. I don't see anything more. All right, any other questions? I know there's a couple more questions.
Yes, well, we have 3 questions.
Okay, we're going to put our betadine again to irrigate and clean it out. Go ahead, ask away.
Okay, the first one comes from Davey Slater on Facebook.
Hi, Davey.
And they asked, can fusions be reversed?
Can fusions be reversed? The answer is no. Fusions cannot be reversed. And any doctor that tells you they can reverse your fusion is lying to you. Don't trust them. If a fusion can be reversed, I could reverse it. After doing over 2,500 lumbar and cervical fusions in my life, in my career. Trust me. Let me have the dilator, I guess, or I guess never mind. Take this. All right, I'm going to show you the incision. But no, fusions cannot be reversed, guys. I'm sorry. I'm sure there's surgeons out there that will tell you they can be reversed, but they cannot. And the reason is this. If you understand the anatomy of the spine, you have this thing called the vertebral body above and the vertebral body below, and then there's 3 joints. There's the disc and there's 2 facet joints. When you fuse at the disc, you're also fusing over time at the facet joints. Because as those facet joints don't move, they're going to get glued together and auto-fuse themselves if you fuse at the disc. So even if you go in and take the fusion out at the disc, you're still fused in the back where the facets are. So the only kind of people that would tell you they could reverse a fusion in the year 2022 are doctors that are scamming you. And I would stay away from them, okay? I know I shouldn't say things like so opinionated, but it's the truth. I'm a pretty opinionated person, in case you didn't notice, huh? No, we just need to hold pressure. Yeah. No, this is just some venous bleeding. About 4 minutes, and then finish cleaning up, whatever you got to do. I'll hold pressure. So there's 2 types of bleeding in the human body. There's artery bleeding, vein bleeding, and then there's, of course, capillary, which is very rare. Only happens in extremely unusual cases. But the most bleeding is artery or vein. Artery bleeding is under high pressure. Remember, your blood pressure is 120 systolic. That means it goes all the way up to 120 millimeters of mercury. So if your arteries are bleeding, you're going to be pumping blood out at 120 millimeters of mercury. It literally squirts, might hit the ceiling, it's so pressurized. Vein bleeding is at 10 millimeters or 12. So it's at 10% the pressure of an artery. And the vast majority of bleeding we see in surgery is vein bleeding. Arteries are pretty easy to avoid because they have a thick wall. And veins, on the other hand, have a very thin, delicate wall. They're fragile. They're easy to damage. So I think we have a little bleeding from her external jugular. External jugular is not the same as the internal jugular. The external jugular runs along the line between the esophagus, sorry, not the esophagus, the sternocleidomastoid muscle and the strap muscles. It runs right underneath the fat of the skin. And in some people, it's skinny and almost non-existent. In other people, it's thicker. And in her case, I think she has a well-developed external jugular. Now, if you're taking antiplatelet drugs or an anti-inflammatory medication before surgery, you always want to stop about 7 to 10 days, at least a week, preferably 10 days before the surgery. Otherwise, your blood doesn't form the platelet plug, which is the first step of clotting. And when you have venous bleeding, which is what she has, you just hold pressure for about 4 minutes, let it clot off. The only time it won't clot is if somebody has some type of a coagulopathy or a bleeding disorder. So we'll see. We're going to give her some more time. I don't know if that's disc or if that's just, that looks like it might be just, it may just be part of the, I don't know what it is, but maybe part of the Raytec.
Maybe a pressure dressing with Tegaderm.
We'll see, yeah. All right, what other questions? By the way, Henry, you should keep asking questions.
Okay.
Don't make me ask you, otherwise I'll forget and the question won't get answered.
Of course. Next question comes from Blue to the Sky again from YouTube. And they asked, do you have ever experienced incompleted disc removal or recurrent disc herniation within a few months?
Great question. So the person's asking, have you ever experienced incomplete disc removal or recurrent disc herniation within a few months? The answer is no, we don't have incomplete disc removal because you can actually see with the scope that the herniation's gone. So the answer is no to that, but do we get reherniation? Absolutely. 100% happens. How often does it happen? It's around 1%, maybe 1.25%. So a little bit more than 1% of patients will get a recurrent disc herniation, and it's always related to their activities, doing something they're not supposed to do. I have had one patient who told me when they reherniated they don't remember doing anything, but you know, you have to wear your collar at night for the first 6 weeks while you're sleeping. You have to wear it 24/7. You can take it off to shower, you can take it off sitting down eating, and you can take it off to do stretching. But you still need to wear your collar. And you can't lift anything over 25 pounds for 6 weeks. Then you can go up to 40 pounds at 6 weeks. You have to keep it under 40 pounds for the first year. If you follow, and then no contact sports. If you follow those instructions, the chance of reherniating a disc is very low, okay? Remember, our patient's face is here, and they have an endotracheal tube coming out. So they're intubated and asleep, and let's see how our bleeding situation is. Oh, it's pretty much just a little bit. Nope, it's gone down. It's about 90% done, but we just got a little more. She must have been on something herbal. Yeah, like ginkgo biloba, fish oil, turmeric, something like that.
Our next question comes from YouTube, from Rigaleb once more. And they asked, if you need to get through the PLL, does it heal after the surgery?
Yeah, great question. So if we have to go through the posterior longitudinal ligament, which we did today, does it heal after the surgery? The answer is yes, it heals, but it's never going to be normal. And going through the PLL, remember, I didn't go through the PLL, the disc herniation did. And so because the disc herniation already tore a hole in the PLL, I just opened the hole a little more to get the herniation out. And will that heal? Absolutely. Yep, totally. So a year after this surgery, the disc is healed as strong as it's going to be, and I would estimate it at around 85 to 90% of what it normally would be. It's never going to be 100. It's probably going to get to around 85 or 90% of normal strength. Great questions, by the way. Just about done. So she's taken a little longer because I think she must have been on something, I don't know what, but sometimes people take supplements or they drink Red Bull or God knows what. There's so many ways for these dietary supplements and natural holistic remedies, and they affect your bleeding. A lot of times they improve circulation, so people feel better. So it's stopped. Can you guys see how small the incision is?
Yep.
4 millimeters. I'm going to give it just another 2 minutes just to be on the safe side. Any other questions?
No current questions.
All right, folks. So hope you've enjoyed this. This has been a really nice surgery. This patient had 3 herniated discs, C4-5, C5-6, C6-7. We went in each one of them and fixed them individually, and we didn't do any fusion. We did it all through a 4 millimeter cut on her neck. You can see it right there. That's it. There's no big incision. There's no real bleeding. We did have probably, I would say, maybe 3 mils of blood loss, about 60 drops total. And we're going to put a little Band-Aid and a pressure dressing. Right, Luis? Like a little thing, and yeah. And this patient's going to go home in about an hour, hour and a half when she's awake. Now for her, home is 2 hours away. Her husband is here with her. And she can't drive today, but she can certainly drive tomorrow. Why don't you type up your questions? In the meantime, let's go ahead and run another video for our audience and type up your questions for me. I'll be there in about 5 minutes to answer them for you. Great job, everyone. Thank you for all your hard work. Good work. That went very nicely.
I think the laser is the best thing out there to help with this type of surgery. It's all legit. That's all I can say about it.
Dr. Deuk here at the Deuk Spine Institute. I'm with one of my patients who's traveled to us from Mississippi. And he came here for the Deuk laser disc repair to be done for a herniated disc on his neck. And he's now here today, just one day after surgery. How are you feeling today?
Feeling great. Feel like the weight of the world been lifted off my shoulders. Feels a lot less pain in my shoulder, no more tingling. Feels like my body's trying to recover back to normal. I think the surgery went very well, no problem whatsoever.
And you're just one day after surgery. Can you tell whether the neck pain is gone yet?
The neck pain is gone, and the pain throughout my shoulder, the tingling, everything is gone. A little soreness in my throat, my voice is a little harsh, but other than that, I feel great.
Awesome. Can you show us your incision? Oh wow, look at that. So you have a 4mm incision. You can see that right here on the surgical footage of the endoscope. We actually, when you watch the video, you can see all the herniated discs back there. We were pulling them out one at a time. You had about 20 pieces. And then you can see the nerve root right there in the foramen. And there's no herniated discs anymore on the nerve root. We got them all out of there. I had to open up the posterior longitudinal ligament and get all those fragments of disc herniation out of the epidural space that were pushing on your nerve. And I got a good look at everything and it looked fantastic. So I think you're gonna do great. Did you consider having like a fusion surgery? Did anyone offer you fusion before?
Yes, I was offered fusion. I was told that was the only surgery that could be done. I started Googling. I come across the laser surgery and I decided to give it a try. And I don't regret it. I think it was the best decision I ever made for my age, and I think the outcome would be a lot more better in the future. And it was a great experience. It really was.
And you work with metal as your job, so you didn't want metal in your neck, on your spine.
No, I think the cold weather would have had an effect on it. I think it would have caused an adjacent effect, is what they call it. When you do the fusion, it make the disc below it or above it wear out. And I'm 34 years old, and if I live another 30 years, I just feel like it would cause significant problems. I think the laser is the best thing out there to help with this type of surgery. It's all legit. That's all I can say about it.
This is Dr. Deuk. I'm here with one of my patients who underwent the Deuk laser disc repair on his neck just yesterday. How you feeling?
I'm feeling better, a lot better. Already, after years of chronic neck pain, I'm already feeling better within 24 hours.
So is the pain that you had when you came here, do you still have that pain?
Not that pain, it's just, I think, a little bit from the surgery itself, but it seems like a lot of the numbness and the tingling in my hands went away, and already starting to feel a lot better.
Now you had a fusion done before, not by me, and you can see the scar there, and then you had the laser surgery done yesterday. And how would you compare the two experiences?
Night and day. I actually, when I had the fusion, had to go back to the hospital with complications. It just took a long time to recover from that. This was much, much better.
Now, your fusion on your neck was done by a pretty famous neurosurgeon, right?
Correct.
Even with him doing it, there were still issues.
Yes.
What kind of problems did you have with the fusion?
Well, I went there for the numbness in the hand and still the chronic pain that I've had for many, many years. And It seemed to take away the numbness in my hand, but the pain was still there. So I spent many, many years going to chiropractors. I've had injections, I've had massage therapy, physical therapy, and it, most of them gave a little bit of relief.
Did any of them get rid of your pain?
Not completely, no. Just kind of made it bearable.
And is your pain gone now?
It's certainly getting there. I'm thinking probably within a week it'll all be gone.
And your surgery was done, even though you had a metal plate in your neck from your prior fusion, we were able to work around the plate and get in there and fix those discs, especially the C3-4, which was, you can see a lot of herniated disc material in there that was causing most of your symptoms. So I'm happy you're doing so well. And you had it outpatient, so you didn't even have to go to the hospital.
Correct. Yeah. Left in about an hour and a half.
What are you going to do now that we fixed your neck?
Well, I'm going to take care of it for the prescribed 6 weeks, and then hopefully I can start getting back to a normal life, be able to get back to golf and things I like to do. Dr. Deuk and his processes here and everything's amazing. If you have a lot of chronic neck pain or back pain, I would highly suggest coming to him.
Awesome. All right, my friend. Congratulations. It is February 23rd, 2022. And I'm here with one of my patients who's traveled from Kansas. Is that correct?
That's correct, Wichita, Kansas.
Wichita, Kansas, and clearly you've had surgery. We just did it less than 24 hours ago. You've got your incision there on your neck. How are you feeling today?
Much better. Much, much better. 26 years ago, I had a fusion of C6 and 7. They told me in Wichita that I would need to have fusions of C4 and 5 and C5 and 6. They set up the surgery for the 23rd March, and I'm going, I can't wait that long. This thing hurts, it's killing me, I cannot sleep, and so on. My husband Dale did a whole batch of research online, and he says, I want you to be able to move your neck after surgery.
Yes.
And
I did
he did a
Googling.
lot of research, and we found Dr. Deuk to be a man of integrity. He films all of his surgeries. He puts many of them online, and you can see for yourself all the good work that he's doing, and that he really, really likes to help people. What he does is generally not covered by Medicare and not covered by some other insurances, but it very well should be, because it really helps people.
So what was life like for you before surgery?
My pain was mostly in the neck and shooting down my shoulder, and especially in my shoulder.
And you had really bad weakness with your arm. You couldn't even lift your arm, right?
That's
before
correct.
Surgery?
That's correct.
Show us what you can do now.
Before surgery, I could lift it to about here, and now I can lift it.
All the way
Yeah,
up.
just the next day, right
You couldn't
after.
do that before.
Yeah, that's because she had a herniated disc, 2 of them, C4-5, C5-6, and the herniations were literally sitting on the nerve, and we got in there, and if you watch this video segment right here, you can actually see there's the laser, and as we're removing the herniation, it literally pops right out of the foramen where it was sitting on top of the nerve, crushing the nerve. So, and the surgery was a success. We lost almost no blood at all, and you can see your incision is tiny, and here you are one day after surgery. It was outpatient, and you're ready to go home, right? You guys flying
Going
back
home tomorrow.
tomorrow? Okay, very good.
Try and enjoy a little bit of Florida today before we go back to the snow.
Okay, it is snowing there, huh, in Kansas?
Probably.
Okay.
If not today, then tomorrow.
Well, stay another week.
And yesterday it was 70
I
degrees
wish.
there.
70 degrees where, in Kansas?
Or maybe that was the day before it was 70 degrees,
nice.
and then they woke up to about 11 degrees.
Ah, so the cold front came in. We get those from time to time, and it gets cold around 60 degrees. But most of the time, it's very pretty here in Florida. Well, we're glad you're here. Is there anything else you want to say to the world about herniated discs in the neck and surgery?
Dr. Deuk will give you a free look-see on the MRI. It's well worth your time. And he will do a Zoom call with you and tell you what he can do for you. So go for it.
I said that it was so important that I said I'd pay for it. You know, because you know, we got a little bit of a nest egg, and sure it's going to cost a little bit, but it was worth it because we got results. I mean, that's amazing.
Your health is the most important thing in the world, people's health. So
You can't take it with you when you pass away.
All right, folks, we'll have a safe travels back.
Thank
Great
you.
to see you. Glad we can help you out. That's a nice.
Thank you.
That's a nice shake. I'm Dr. Deuk Majan, and we've just wrapped up cervical, which is the neck, Deuk laser disc repair for a patient who has 3 herniated discs in her spine. She came to us from Florida. She found us on the internet. She's watched the surgeries for a long time, and she's been asking questions, great questions, probably for the last year. Anyway, what is significant about her story? Well, she, like many people, have herniated discs. So what is a herniated disc? Well, if you look at the spine, and we're just going to take part of the spine here, you can actually see there are bones, and there's a cushion between the bones called the disc, okay? And her disc is injured in such a way in the back that the jelly from the center of the disc, and maybe you can see it here, if I turn it this way, we're looking down the spinal canal where the spinal cord is. You can see the jelly coming out like that, and it narrows the spinal canal, okay?
We see it.
All right, good. So if we take the disc out and kind of look at it, what's going on here? The disc looks like a cushion, like a washer, and it's got 2 parts. It's got a very strong wall called the annulus fibrosus. Fibrosis for fibrous, meaning tough. And it's got a jellyish center. It's kind of like silicone. It's cured. And in the back of that disc, there's a tear in the wall from trauma, and the jelly from the center, the nucleus, is pushed into that tear, and it's bulging out. That is what a herniation is. And there's many names. It's called the disc protrusion, prolapse, herniation, extrusion, bulge. There are literally 10 different names for the same thing, okay? And the reason I say that, discs are very simple. They're not complicated. They're just a wall of 25 layers of collagen and elastin with a jellyish center called the nucleus pulposus. It's pretty inert biologically. And really, there's no blood supply except for the outer part of the disc. So that when patients get a tear in the wall and the jelly pushes through, it's literally called the herniation. Keep it simple. So she has 3 discs that were herniated, and we fixed all 3. And the way we did that is we went through the front with a tiny tube to the back where the tear is, and I used a laser to clean all this jelly that's stuck in there, keeping the tear from closing. Now she's got the ability to seal off. Her body will heal that disc on its own naturally. The surgery took us about an hour and a half to do. She was asleep for it. Her positioning was to where you could see the front of her neck, and we went in on the left side. There you could go on the right, you can go on the left. You could see the trachea in the middle with the esophagus behind it. We went on the left side, and I went in right over the middle disc, which was 5-6, and then I used the play of soft tissues. I kind of pulled down. I got to the next disc at 6-7, then I went back up and I pulled up and I got to C4-5. So using one 4mm cut, I was able to fix 3 herniated discs. Now, this patient didn't want fusion, and neither should you. This is what a metal plate looks like attached to your spine, okay? Her spine has no metal plate. Hers is natural, and that's the way it should be. You get movement, and she still has movement at her disc. When you have a metal plate, there's no movement. It's stiff. So you're going to lose the flexibility of your neck. Plus you got a metal plate there right behind your swallowing tube causing swallowing problems. You got all that scar tissue from the surgery itself because there's a big incision. You have bleeding. You have risk of infection that's high. You have complications. You have adjacent segment disease. There's so many bad things about doing artificial disc and spinal fusion. Even laminectomies and foraminotomies, the surgeon is literally going in and they're drilling a hole in the back of your spine and taking out your ligaments and normal bone just to get to where the herniation is. Foraminotomies don't work. Somebody asked, why don't you go through the back? Because going through the back doesn't work. The problem is in the front. The problem is in the front of your spine where the disc is. It's not in the back. People go through the back, surgeons go through the back because they don't know how to go through the front properly. So my advice is don't go to a surgeon who wants to go through the back to fix a herniated disc, because a herniated disc is literally in the front part of your spine. It's just in the back of the front part. Don't go through the back. All right, any questions? Great, hope you enjoyed it. We're going to be back for a Deuk laser disc repair 4-level lumbar next on a patient who's from Georgia, and he's got back pain from the herniated disc, and he's got symptoms into both legs, which include weakness, numbness, tingling, and pain. So we're going to get him fixed up next. Thanks for joining us. I'm Dr. Deuk.